So my case today is a post-CABG case. And to answer Dr. Colombo, he's not here, but he told us that he didn't see interventionalists refusing to interfere or the contrary, refusing the case. It's always the inverse. So I wish that I could refuse this case and the surgeon continue his career, but we were obliged. This patient actually is one of the most difficult and one of the most complex cases. He's a male patient, age 76 years. His clinical presentation is as follows. At 11:40 p.m., he presented to our hospital with extensive infralateral STEMI, hypotension. His blood pressure was 80/50, and impending pulmonary edema. Echo was done in the emergency room, and it showed an ejection fraction of 25 and moderate mitral regurgitation. His past history had a CABG surgery, 3 grafts, 2008, and his lab tests, he showed the diabetic ketoacidosis with a random blood sugar of 600 and severe renal impairment. His creatinine at presentation was 4.2. So this was the situation, 11:40 p.m. in the evening. Still I'm examining, I have 6 patients to see in the outpatient, and then they send me the ambulance, please help. This is his coronary angio, and I'll stop after the coronary angio for taking decisions. As you can appreciate, this is a very tight 99% stenosis in the left main, and the distal CX is diseased a little bit. Some calcification in the mid LCX, and this is chronic because he had this from before. We got the report. This is lasting more than 10 years. He's the right chronic CTO also, dating since the last, he had his CABG at 2008, and it's giving good collateral to the very distal OM. Here is the graft, which was mentioned to be on Aramis, but actually, okay. And you appreciate that this is infralateral STEMI, and from this angio, maybe there is a thrombus in the proximal segment. Appreciating from here, yes, it's full of thrombus. And here is the lima, showing good lima, but the distal LED showed tight stenosis and giving collaterals to the PDA, and this is his venous graft to the right coronary. So our patient presenting late night, nearly midnight, with this situation, almost cardiogenic shock, and pulmonary edema, diabetic ketoacidosis, severe or moderate to severe renal impairment. His creatinine is 4.1, and ejection fraction of 25, moderate mitral regurgitation. I'll stop here. What to do? Infralateral STEMI, extensive infralateral STEMI. No heart team in emergency. No heart team. Yes. I repeat the angio once again. Actually, this left main is dating since 2008. This coronary angio, we got the report, and this is the same coronary angio, the native vessel, as 2008, for which he did his CABG surgery. So this is my question to the panel. Which to tackle, which to do, and which is the culprit? We have venous graft to the ramus or the diagonal. Here it appears to be ramus or diagonal, which is occluded and fresh of thrombus maybe here. As you can appreciate, there is a thrombus here. Maybe this is the culprit lesion. This is the acute. And we had an occluded graft to the, of course, the lima. This could be progressed, the LAD, the distal LAD. And as you appreciate here, the right coronary. Is it this right coronary the culprit? I don't think so, but this is my question to the. Yes. 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 Okay. Okay. 2008. He had the bypass graft surgery 2008. So it's, and this had been done. $11 years, yeah. Okay. Which one? Which one? Which one in you? Yeah. So, first, yeah, okay. Yeah, this is my question. This is my question to the panel. Yeah. Here. Okay, I'll see you. But for the sake of time, I'll go rapidly with the case. Yes, okay. This is a case. He's a male patient, age 76 years old. His clinical presentation is infralateral STEMI with cardiogenic shock and impending pulmonary edema. He was wet also. The echo in the emergency room is 25%, moderate mitral regurgitation. He had the past history of CABG surgery 2008. We had the report of the coronary angio and the grafts, but we don't have the CD before because it presented in midnight, exactly, 11:40 p.m. Lab tests, he showed diabetic ketoacidosis with severe hyperglycemia, and the random blood sugar was 600, as well as severe renal impairment. His creatinine was 4.1, 4.2. And this is his coronary angio. The left main, as I can appreciate from the report of the angio before, dated 2008, it's the same native. He had the same subtotal occlusion of the left main and the same RCA proximal occlusion and giving collaterals to the distal LCX-OM. It's the same. We haven't got the angio, but it's the same, I think. And then this is the venous graft. It has been reported to a ramus branch, which is occluded very shortly from the aortic anastomosis, and we can appreciate thrombus. Here is the lima well functioning, but the distal LAD is poor and showing tight stenosis, collateralizing the PDA. And this is his venous graft to the right coronary. And the question now was, which is the culprit, which to start, what to do. We have a patient with cardiogenic shock. We haven't got Impella. This is...
we started the discussion,
yeah.
but assumption, you need a heartbeat at night or the day. Okay, no. The question number two, you open the culprit or the vessel which is moved by throat.
Which is the culprit, yeah.
Whether it is usually, which is the culprit, which is the culprit, which is the culprit, the graft. You open the graft.
Yes, which... Yes, this is another question because the also the right, the collaterals, yeah, coming from the right coronary to the L circumflex here. Okay, the collaterals from the lima is coming. Here is a good collaterals to the distal LCX. And this is from the lima. I'm sorry, for the sake of time, I have just this projection also, only. And to the PDA also, from the lima to the PDA. Here. Here. Okay. Okay. Yes. Okay. Actually, my question was to do intra-aortic balloon. We haven't got Impella. The patient is 80/50. Yeah. Yeah. Actually, I didn't get the balloon pump. I was very hurrying because the patient was in a very bad state. So I said I must open the left main first. No, the left main. Despite that, it was the patient during inflation. The situation was much worse, of course, but I went very rapidly. So this was the circumflex. Proximally, there is no calcification. In the distal, it's a little bit calcified from studying the angio. So this is preparation, good preparation. Here is a long stent, and this is the deflation, and this is pot, and this was the situation. Here I said maybe I'm in a better situation a little bit, but still the patient was ST elevation on the monitoring, and still the patient was restless a little bit. He was under CPAP at that time. We asked him if you're okay, still chest pain. So I said no way, the blood pressure didn't come up. It's still now after inflation. During inflation with the left main, it came down to 60/30, but later on I was very rapidly doing that. Then the blood pressure came back to 80/50. And the patient there is ongoing pain, as he stated. He's still restless and he's still having the pain that he came with. So this is the final result. I didn't go to the distal circumflex, the mid LCX. I got TIMI3 flow. So what to do next? I think CX. Okay, I went with wiring. I went with the aspiration balloon. It couldn't pass. So without contrast, and the patient has creatinine elevated, I didn't have any contrast actually here, very little amount. No way to cross, but there is little calcification here. I had to crack it, and then I took a contrast here. Then I think I went with the balloon because I had a problem ballooning. Then here I still haven't got any flow. Here is the aspiration catheter. I tried before, but it couldn't pass. And then I dilated with the balloon. It couldn't pass a little bit. Then this is the extreme of it. But actually, after that, I got a flow a little bit, without crossing till the end. But we aspirated white thrombus, and then this is the flow. We waited here a little bit to stent or not. I had an experience before leaving a patient like that. It closed. Yes. But I'm sorry we haven't got any good images because this is what can we. So it's a good branch. Yeah. It's a diagonal or ramus, yeah. Yes. Yeah. So we waited a little bit. We had this is okay. And after that, the patient actually collapsed. Once again, it closed. So I got with the balloon. I opened it with the balloon. I said, no way, I had to stent it. This is a 3 or 3.5, no, 3 by 38 everolimus eluting stent. And taking it by pot. And this is what we got. The patient, a little bit blood pressure 90/60. We stopped here. I said it's okay. Anything to do more?
I have some questions about thrombus in the graft.
I'll continue after the question. No. I'll continue after the course of the patient.
The use of thrombus aspiration in graft, there's no trials. They use it to be inside the graft. We don't have trials, The third, protection for the grafts. While doing the graft, we also have nowadays at the beginning we put a protection device inside the graft while we're doing the graft. So what's your experience in such a thing? But in settings, we don't
Yeah. Okay, I'll continue the course of the patient. I stopped here. I said he has diabetic ketoacidosis. There is hyperthrombotic state. It's time for chemistry to play a little bit. Actually, he was intubated after that. Okay. I won't be too long. 2 minutes, just 2 minutes. Yes. The CPAP was replaced by, yeah. Inside the cath lab to transfer it, yes. Because the patient was in pulmonary edema, his blood pressure came a little bit. He came to 100/, 70 by support by noradrenaline, but actually 72 hours he was extubated. The ejection fraction came to 35. His mild to moderate mitral regurgitation persisted. Clinically, the cardiac condition, he was better in the hospital, but hemodialysis was performed 3 times, stabilized after 6 days, O2 mask only in the intensive care, but actually in day 8 he had severe chest infection, re-intubated with a fever, and white blood cells came out, and actually with the severe infection, unfortunately the patient died in the day 10. No, he died without any ST elevation, no. Then this is, to conclude this case, this is a shock patient, STEMI, post-CABG, diabetic ketoacidosis, serum creatinine is elevated, ejection fraction 25, pulmonary edema, PCI of native and recanalization of venous graft. That's what I think about. No intra-aortic balloon, but of course, if we had the Impella, it would have helped a lot. CPAP intervention, adequate revascularization, but poor outcome. Day 10, we had the patient died. That's why I'm introducing today. So 76, 78. No, he's an old patient. He's a very old patient. And he looks in the 80s. Okay. I had one of the opinion with the team. He told me, you had a success, we had this was minimal contrast. We didn't exceed 100 milliliter with all this intervention. It took 2 hours, but without contrast. He kept insisting to go for the right coronary. But I said, no, the patient now, the blood pressure came up a little bit. The patient is better. I don't want to lose the patient in the cath lab. So I stopped. I said, this is the chemistry. His blood pressure came up and the blood glucose is 600. I should stop here. Maybe later on, if the patient stabilizes and hemodialysis, I can go for the LAD to put a stent there, but if he stabilizes, and then tackle the right coronary. This was my concept, because after 2 hours working and the patient a little bit, I wanted to get the patient out of the cath lab and see what's going on. But maybe you are right.
I
No, I didn't go for the right. I stopped. They asked me. Yeah. Okay. Yes. No. The graph to the right. The graph to the right, I had an impression, but not from this angio view. There is another view. It's been collateralized. It's the right coronary. I think it's old occlusion. The fresh one was a thrombus in it. Yeah. So I didn't want. Yeah. 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 No, but no. I thought this is the culprit because there is a fresh thrombus actually, and we've aspirated the white thrombus finally. But you are right, maybe. But other team told me why.
Thank you very much.